lecture is going to come first now, and then we're going to do some question practice exercises. And after the break, instead of delivering my second lecture, I'll deliver my first lecture so that we can stick very much to time as much as we possibly can. So I'm looking now at the legal and ethical issues regarding the MFD examination, regarding the diploma examinations. I'm trying to give you as much of a brief nutshell of what you may find useful as far as the examination is concerned, and going through some of the very basic principles with you. We're looking at ethical and legal practice of dentistry. The definition of ethics is that we practice in accordance with a moral philosophy that involves systemizing, defending, and recommending concepts of what is right and what's wrong. You can see that there are many, many big words being used without a tight definition, because in ethics, you're looking at 4 words or 4 very, very brief phrases: autonomy, beneficence, non-maleficence, and justice. In other words, there you allow the patient to make his or her own choices, but above all, you do not do any harm to your patient. And this is the basis of which the practice of medicine and dentistry of healthcare profession is based on. As far as the practice of dentistry in Ireland is concerned, this is defined in the practice through the ethical guidance issued by the Dental Council, which, if you practice in Ireland, you're registered to be a practitioner in Ireland, you're bound by or you have to observe. And it's a very, very similar situation with the United Kingdom General Dental Council. These guidelines from the Dental Council in Ireland has got quasi-legal status. In other words, if things come to blow, if these things go horribly wrong, you go to court, and the court would then look at the guidance issued by the Dental Councils and say that this is what the acceptable behaviors are. And in relation to dental councils, you're looking at what they say about professional misconduct. In other words, is your behavior professional? Is your behavior in accordance with the minimum required standard? In exams like an MFD or in the diploma, very often in relation to law and ethics, the issues of negligence arises, because this is part and parcel of what, as clinicians, we always face. To establish negligence, the following 3 elements must be present. Number 1, legal duty of care. Number 2, a breach of that duty. And number 3, foreseeable harm has resulted as a result of the breach. It's similar both in the Irish law and UK law, in that the basis of which are adversarial. In other words, there's a lot of very, very strong common law basis with which these are based. And I'm going to go over these 3 elements with you. These are very easy exam questions to set both in MFD Part 1, the diploma, and very often how you interpret certain clinical situation in part of the OSCEs in Part 2 MFD examination as well. So remember the 3 elements that you need to establish negligence. The first element is duty of care. Once the patient has been accepted for treatment, you owe the patient a duty of care. In other words, you're not going to do any harm to the patient in respect of what you do. In other words, no duty of care, no negligence. If it's somebody else's patients, there's no negligence against you because you are not the patient's dentist as such. This is the first principle. So this is a common sense approach, so it is important you know and you establish whether it's your patients or not in the first place. The second element that is required is that you need to perform to a standard that is reasonable of what a reasonable professional should do. In other words, that the standard of care required has to be tested as being reasonable in accordance with what we call the Bolam test. It is a test set by your own peers within the range of acceptable practices, and it is obviously not to a particular standard, it is to the particular minimum standard that is acceptable. In other words, it does not deal with ideal standard, it deals with what demonstrate would be the minimum acceptable standard that is required of you as a professional. In other words, there, you would do something that you would otherwise not do in accordance with good practice, or vice versa. In other words, there, you may therefore have deviated from this minimum standard. In other words, also that you may have breached your duty of care. For instance, periodontal examinations. You would have carried out a basic periodontal examination in these type of patients, and you hadn't. So there is, in theory, a breach of duty of care. Now, I mentioned basic periodontal examinations because in your multiple choice, if you're doing part 1, and in also your diploma examinations, if you are in Ireland sitting there, or even an MFD 2 exam, that these are hot topics that can be asked very easily because they are defined outcome, very easy to set questions on. This is a test which Bolam test again now. It is in accordance with the case in 1957. It was held that the standard of care demanded by the doctor and in the dentist, by necessary logical extension, was that of the standard of a reasonably skilled and experienced practitioner. I'm not going into this case in detail. There are different preparatory programs that we run where we have a lot more time, which we're going to go into the nuts and bolts of these cases, but this is the essence of it. The problem with this test, though, is that if one body of opinion said it is very reasonable that you do X treatment and not Y, another body said you do Y and not Z, etc., etc., who would you believe? The law was clarified in 1997 in the case of Bolitho, in which case there was a medical case in which Patrick Bolitho was a child suffering from acute episode of asthma at the age of 2. He had been hospitalized many, many times. And on this occasion, he was hospitalized again because of acute asthmatic attack. And there were 2 schools of opinion. One school of opinion from the surgical point of view was to intubate him, and the second from the pediatric point of view was not. The pediatrician got to him and treated in accordance with the pediatric guidelines, and unfortunately he passed away, he died. So there was a legal case going on, and the pediatric doctors were sued, and the pediatric doctors said, look, these are my guidelines, textbook guidelines, I follow them straight away. That wasn't a problem, but unfortunately the patient still passed away. But the plaintiff said, oh, hang on, the surgical guidelines suggest you should do something else. You didn't follow that, that's why he died. What the court ruled was that both were logical and both were responsible opinions, and therefore either of one would stand. So as a result, there was no negligence. As a result, then there was no breach of duty of care and no negligence. So you need to look at the basis in which how you form the opinion. It is very important, therefore, for us to know that guidelines issued, say, for instance, by the Irish Dental Association's Dental Council, College of Surgeons, honest, responsible, reasonable bodies do have a quasi-standing in law that if you follow, you are compliant to good practice. Whereas there are other guidelines which may not be. So you need to look at these aspects very, very carefully. The latest development of it is further tightening of this, because even with those guidelines, you say, yeah, I follow one and not the other. When would you tell actually the patient the particular risks of these treatments and the risk of non-treatment and risk of problems? Chester case deals with somebody with back problem. And back problem as such there, that's called equina contusion, with this condition that you need surgery in some cases. And in 1 in 15,000 chances that there could be complications that you end up far, far worse. In this case, Mrs. Chester was the patient, and Dr. Afshar in the Oxford Royal Infirmary carried out this operation without any problem. But unfortunately, this 1 in 15,000 complications manifested itself, and she ends up on a wheelchair, not being able to move at all as such. So Mrs. Chester soon said, hang on, had you told me about this risk, no matter how little it is, I might have thought about not going through the operation, even though I might still have to because my back pain is so bad. But you never gave me a chance. The ruling was that, okay, if the risk is very, very rare, so rare that there were only 3 cases reported in Australia and not elsewhere in the world, in your professional opinion, in your professional body, you said that's so rare you don't have to tell the patient a particular risk. But if the patient, like Mr. Chester, who wanted to know about the particular risk, is so keen on doing so, you will have a duty of doing so. In other words, the difference of it is it brings together what, say, for the law in the UK and the Irish law together as such. Because in Ireland, no matter how little the risks are in relation to these, you have to disclose it to the patient. And there was an Irish case, year 2000, Harris against McGeegan. This is a case of implants. Similar situation about minimal risk that ought, in theory, to be communicated with the patient but was not. And there were complications. So these two, no matter what you do, different piece of legislation, different jurisdictions comes apart. So in other words, the clinicians might recognize the patient's right to autonomy, but an informed choices. So if in doubt, make sure you tell the patient the potential risks there are. And these principles, in terms of the examinations, will not be tested in the exam like this, but they will be tested, they can be tested in, say, OSCE's examinations, when part and parcel of what you've been asked to diagnose, what the conditions are, what the prognosis are, what are the potential complications in relation to doing this to the patient and not, you need to be able to interpret them. And these questions can come in through the clinical reasoning papers as well, in directly asking you a scenario and see how you actually interpret it. How would the court know what is right or what is wrong, what to do? And the court is effectively advised not by the law book, but by expert, because this is a common law approach. So expert, expert dentist, another, will be writing reports to advise the court what is right and what is wrong in terms of clinical acceptance, and the law courts then decide. There's also a time limit. In other words, if it is, say, in the Irish jurisdiction, you've got 2 years after the event to sue for negligence, patient-wise, and in the UK, 3. But the problem there is that the 2 years or the 3 years does not start until the particular patient needs or should have known about that particular risk. For instance, a separate file in an endodontic treatment which had failed, if it caused problem as a result and the patient didn't realize that there was actually a separate file, the time period for action to be taken does not start until the time when the patient should have known, not when it occurred. We also need to look at minor aspect of our contract, because for dental treatment that we give patients, we charge patients for this as well. In other words, there is a contractual relationship between the practitioner and the patient. What is a contractual relationship? You need to offer something, number one. Number two, somebody else needs to accept the offer. Number three, there has to be a valid consideration, in other words, the passing of finance money. Otherwise, the contract does not exist. Now, the difference of here is that if you buy, say, dental materials from a supplier, supplies to you, you pay, there's a contract. But what about patients, say, go into a hospital where there is no payment involved? There's no payment here. Is there a contract? In certain jurisdictions, there is, because the transfer of money comes from a higher level through block contracts, etc., not from the patient. In some contracts, in this country, there are none. But the difference, the main difference is that in both cases, there is a same duty of care. The duty of care that you do not cause any harm to people that you see, you treat, etc. So the supplier must not supply something that is not good, not fit for purpose, for you to use on your patient. And you, whether you charge the patient or not, then you have the same duty of care not to cause any harm to the patient. So it is these two things that are separate. But what should you do in practice? You should manage the patient's expectation, because there are a lot of other risks that is arising. If, like James Bond, the world is not enough and the patient wants the world, be very careful, because the patient's expectations may not be something that you actually can deliver. So the copped-out situation, I'm not saying it's just right all the time or not, is not to take the patient on, so there is no duty of care, there is no problem in respect of negligence. Practicalities also, what are the pitfalls and the risk of treatment? In this situation, should the practitioner have taken the CBCT scan, used the stand, bone augmentation? What about the angulation of the implant fixtures, and what are the potential problems? And if this is indeed the case, you deviate so far away from normal practice, did the patient actually consent to the treatment or not? Because there are issues on this. The names underneath those are the names of cases, which you do not have to remember, but these are very, very commonly bound and supported through the common law situation. In any case, if you have undertaken some treatments, has it been undertaken in the best interest of the patient? It looks like that upper right one, it definitely has been, because the patient certainly has benefited from it. The casing point here, though, is that if the patient does not consent to the treatment, even though you may do the patient a power of good, you still shouldn't have done it, because treatment has to be done with consent. So only treat patients when valid consent can be or has to be established. Again, this common OSCE questions that ask you to identify these, and common multiple choice questions if you're sitting part one about what is required. So the patient needs to have the capacity to consent. If a patient is unconscious, no. It needs to be voluntary. It cannot be held with a gun in the patient head. Are you going to do the treatment or not? And you also need to disclose sufficient amount of information, of which we have already illustrated what it is. Consent can be verbal, can be written, or can be implied. Properly administered, of course, written consent provides the clearest evidence that the patient does in fact consent to treatment. And in relation to the Dental Council in Ireland, if you're undertaking any conscious sedations, IV sedation, or general anesthesia, it must be in written form. Implied consent is, as such, by the action or words of the patient, you say that the patient is consent. Say, for instance, if you work in the unit, the patient rings up and makes an appointment with you, turn up for the appointment, fill in the medical history form, comes in your dental chair, sit down, open her mouth or his mouth, the patient actually does consent for an examination of the teeth, not for any other treatment, because this is by action. So it's very important to distinguish that. Consent, of course, you've got legal guidance, ethical guidance as well from the Dental Council here and from the General Dental Council. And it is important that the patients either express in terms of words, in terms of writing, or implied by the patient's action that he or she does in fact consent to the treatment. So implied consent is to do with the conduct of the patient. Express consent is usually in writing, or that the patients say, yes, I will do it. So you have to explain also, for valid consent to be valid, the nature, the purpose, effects, the chances of success, alternative, risks, and all that you have to explain to the patient. Consent form is useful because if you have a consent form, legally speaking, the onus of proof that there has not been any consent has been shifted from you, for the practitioners, to the patient. The higher the legal threshold it is on the burden of proof, the less likelihood of somebody taking out a case against something that is not shoe-in situations. So it's just in relation to risk management. For consent to be informed, patient obviously only need to be informed on broad term basis as to the nature, purpose, etc., of the exam. Note that this was 1981. In practice now, it has to be a lot more in detail. So if in doubt, do tell the patients what they are. So in terms of good practice, you should explain to the patient the risk of treatment or non-treatment, like the endodontic treatment, extrusion of materials, trauma of the front teeth, what to do, where the fragments would have been lodged, use a particular implant system, whether they're useful or not, or exposure of a canine, what the risks basically are, so that you can actually get a real consent. As part of the consent process managing realistic expectation, patients need to know that even the best possible procedure, best possible outcome, not all treatment will be successful. Patients also need to be competent. In other words, the patients need to be able to consent himself or herself. In a situation like this, it is the age of 18, for sure, 16 by assumption. If the patient is below 16 or further below on that there, you're looking at the cases where patients cannot actually consent to treatment. Now, there is something called Gillick competence, which we won't have time to cover that, but if you have time, read to see what that is, because that is an important thing to have. You also have a duty of confidentiality not to disclose healthcare information that you learn, that you earned, as in your capacity as a practitioner, so that the information rests with you and you do not spread those information. But there are exceptions. And I have seen those in the Part 1 paper, because these are easy questions to ask, true or false. In these circumstances, you can disclose. In those circumstances, you cannot. For those of you who are actually undergraduate students here, you can actually see that they are very, very common and similar to what you actually learn in the BDS level. So as far as the gap towards the Part 1 of the MFD or the diploma examination, the gap is not that great, because we are testing and asking for something that is slightly beyond the undergraduate level, but very, very reachable, very reachable. You need to know the pillars of clinical governance. Part 1, very easy to set question. What are the 7 pillars of clinical governance? Clinical effectiveness, risk management, patient experience. In other words, you need to know the measure of which or with which the improvement of health can be obtained through these particular process. Know your complaints procedures as well, and I'm going to almost skip this slide because I haven't seen any exam papers related to this, except a very, very minor part of it. But if you have time, do read about them, because in part of the OSCE, they can be asking you similar questions. However, clinical audit and the audit cycle is in section 131, 132. These are very common topics to be asked, both in Part 1 and Part 2 of the examinations. Audit cycle is that you identify a problem of an issue, identify aspect of where you might not meet the required standard. You set the criteria. You don't meet exactly the standard, like radiography standard. You observe and you practice, and you collect data to see what you're actually doing, how far you're away from it. And then you compare those performance with the criteria and standard, identify changes that you need to undertake, make those changes, audit again, implementing changes to see whether you have got an upward spiral of improve in standard and outcome. Okay, thank you very much, ladies and gentlemen, for this. Thank you. Now, I'm going to go straight in for the next session of our program. Now, there is one announcement that we have to make, which is the housekeeping matter. This is for those of you here, not for those who are streaming from the Middle East and the Gulf region. For those participants of this intensive preparatory program, if you're thinking of entering MFD 1 in Belfast for the 3rd of April 2017, or the Diploma in Primary Care Dentistry here in Dublin, the entry to these examinations will open again now until the close of business on Wednesday, 1st of March 2017. The exams office here have got a list of participants of these courses. So any of you who wish to avail this opportunity should email Ms. Katie Lombard with the email here, Katie Lombard, one word, at rcsi.ie on or before Wednesday to indicate that you wish to enter the examination, and she will reply with a link so that you can actually enter those examinations. We hope so far you've found that what we are delivering here now is not too difficult to manage. You will actually manage that. And I'm also now going to show you some aspects of sample papers as to how or what the exam papers may be like. Now, I must put in a disclaimer first, because number one, oops, sorry, wrong one. Clicked the wrong file out. These are sample MCQs and SBAs. These are simple question and answer. They could appear in your exam in similar format, but they have not been proof checked nor been submitted to the exams committee, otherwise we will not be allowed to show this to you. So I cannot vouch 100% accuracy of the information, lack of typo, or correct answers. So these are some suggestions. So we accept no responsibility for the accuracy of this. However, please no phones, camera, iPads, or tablets on this one, okay? Now, if you are going for part one, you're going looking at MCQ multiple choice questions. Multiple choice question, you're going to have 75 of them. One statement and 5 branches. They relate to one event, and you're going to independently say A, B, C, D, and E, whether they are true or false. There's no negative marking. So in other words, if it's not true, it's false. If it's not false, it's true. Because there's no negative marking, we will ask, please guess. Do not leave it empty. Otherwise, you do not score any mark. Obviously, a chimpanzee will score 50%, true or false. So the pass mark you would expect would be higher than 50%. But don't leave anything empty. We also find that some candidates would mark both the answers true and false. You do not score anything if you mark both because you are guessing. So read the instruction very carefully if you're sitting those examinations. It asks that you use an HB pencil. If you haven't got one there at the exam center, there will be one provided for you. If you use 3B pencil, even if you try to rub it, the graphite might still be there. The machine will still read that you put an answer in there. You're defeating yourself. So make sure you read the instructions. And also, there's plenty of time for this paper. So if you want to sit this paper, think carefully, but there's plenty of time. There's no hurry in it. You have got plenty of time with it. Okay, first one. Which of the following requirements must be satisfied when gaining informed consent from the patient? Very topical there just now. A, the patient has a chaperone. False. B, the consent is voluntary. Yes, true. C, a written list of warning must be given. Must? No. It should be given? Yes. So must be given is false. So use of the word must, might, should, would, just read it in between the lines. The patient understands the treatment plan. True, because if the patient doesn't understand that, the patient cannot consent. Patient is over 18 years of age. False. What I haven't mentioned there just now is that 16 is the legal age in which you can assume consent. But what about if the patient is 14, 13, and 12? Well, if the patient understands the nature, purpose, effects of treatment and non-treatment, and be able to digest the information, you might say, yeah, the patient can in fact consent. It is the Gillick competency case, applying that principle for anybody below the age of 15. But is there an actual limit? What about 14? What about 13, 12, 11, 10, 9, 8? Well, the answer to that is that the lower the age it is, if the patient comes in on his or her own, you need to question about child safety. If a 6-year-old wander into the surgery and say, can you feel my tooth? The first thing is, hang on, where are your parents? Why are you coming here? But the absolute minimum age for somebody to consent to treatment, absolute minimum, is 10. Reason for that is that a little while ago, there was this young person, 2.5-year-old, called Jamie Bolger in Liverpool. He was abducted by 2 10-year-old kids. And he was put up onto the railway bridge and pushed down the railway. He was run over the rail. He was killed. The courts ruled that the 2 10-year-olds at the time were guilty of murder because they knew exactly what they were doing was wrong. They knew exactly what the consequences were. So they knew that there were consequences of taking life away. So they were actually guilty of murder. So if you are found guilty of murder because your understanding is sufficient to be able to commit such a heinous crime, you could consent to them to treatment, no problem. So therefore, the legal minimum age is 10. But don't go anywhere near that. Now, these are useful information for Viva for part 2, because the scenario is the lower the age it is, well, what would you do? 14, 13, 14, that is the absolute minimum. Because anything below that, there hasn't been a case law established, and also that where are the parents? It will be child care and child protection issues that arises. Okay, number 2, which of the following are known to be risk factors of oral cancer? Note the word "are" here. If this paper has gone through the exams committee, probably will be chucked out because it will have been said which of the following are known to be the risk factor. R tells you that there is more than one true answer. Tobacco consumption, true. Substance abuse, true. Alcohol consumption, true. High level of stress, false. Previous trauma to the site, false. The other factor for oral cancer is HB, human papilloma, HB virus. You need to know HB16 in particular, particularly on young populations, the increasing evidence of that in. Number 3, which of the following statements are true regarding Hall technique of fitting permanent metallic crowns? Requires extensive caries removal, false. Requires administration of local anesthesia prior to commencing the procedure, false. Has equal access or success in primary, secondary dentition, false, because you don't actually do it on secondary teeth in the first place. E, requires occlusal reduction so as not to create a high restoration, false. Superocclusion in this is perfectly acceptable because it will settle in very quickly. Now, Hall technique as such is something that is very frequently examined both in part 1 of the exam and in part 2, OSCE as well. In terms of OSCE, it's to show you a clinical picture and to ask you to interpret those events and then be able to answer those questions. Question 4, regarding dental amalgam. Is a mixture of silver alloy and mercury true? It can be composed of spherical particles, irregular particles, or a mixture of the two, true. Gamma 2 is the name given to the silver mercury phase. Not quite, it's actually the tin mercury phase, SN7HG, so this is false. Dimensional change is said to be negative if the amalgam expands during setting. Well, it's defeating itself if its setting is expanding. Sorry, if it is positive, it is expanding, so no. Titration is the process of mixing silver alloy and mercury. This is false. So on and so forth, and I'm going over a couple more of this for you. Now, this is radiography, number 5. You've taken a radiograph to assess the lower third molar for surgical removal. Which of the following features would suggest that the patient would be at risk of suffering from damage to the inferior dental nerve during the removal of this procedure? A, loss of tram lines of the inferior dental canal, true. Deviation of the tram lines, true. Widening of the tram lines of the inferior dental canal, no, nothing to do with that. Narrowing of tram lines of the inferior dental canal, yes, because that tells you restrictions on it. Radiopaque band across the root, false. Now these are standard of how you would be expected to know or not know in MCQ examinations. Not too difficult, is very immensely workable and possible. Now I'll do one at the back here for you. Regarding aesthetic dentistry, number 8. Golden proportion is the ratio between height and width. The gold proportion is 1.5 to 1, blah, blah, blah. No, it's not. It's I think 1.2, 1.25 to 1. When considering the symmetry of a patient's dentition, the width of the teeth is more noticeable than the height, which is more noticeable than the depth of the teeth. True, this is indeed the case. C, when considering symmetry of the patient's dentition, the depth is more important than the height, which is more noticeable than the depth of the teeth. False, and so on and so forth. Black triangles, which appears with the loss of gingival tissues, are much more noticeable in patients with low smile line. False. High smile line, just true. Desirable maxillary gingival contour has the highest gingival margins over the central incisor, followed by the canine and the lateral incisor. False. Now, excuse me. So you have a range of different questions that you ask. Over here, 5 branches out from each question. The second bit of what you have is a single best answer, of which there is only one statement that is true. So do not enter more than one on your answer sheet, otherwise you don't score anything. But do enter one because you've got a 1 in 5 chance at least of getting it right. The exam technique for this is usually that what you should do is to eliminate the answers that definitely are not going to be the correct answers and look at those remaining, which ones would be the most likely to be the right answer, unless you know the answers straight away as such. So we have an example. Patients with asthma should not be given NSAIDs, as this may precipitate asthmatic attack. Patients with asthma should not be given codeine-based analgesic drug. Patients with asthma, C, must not be given intravenous sedation. D, asthmatic patients should not rinse their mouth after using salbutamol. And E, patients with severe asthma should not be given local anesthesia that contain adrenaline. The answer to that best fit is A, because about 10% of patients with asthma may have similar reaction or may have the NSAID precipitating the asthmatic attack, and therefore you should not give that to patients. Now, I'm going to move on to the second part of the tips for you, and I'm going to combine this with or between the CRA, for those who are sitting the diploma, and the OSCE, because they are asking very similar questions. And this is how it's going to look like, particularly in a Part 2 OSCE situations. You'll be given a clinical photo. You'll be asked to interpret the clinical photo or a radiograph or an artifact, or say, for instance, even an artifact like a denture or a model of an upper removable appliance or something like that. There will be a script telling you what it is, describing the situation, and then you start answering the question. The only difference to that is that in an OSCE situation, each station here is 5 minutes. So 5 minutes, you move on. You start with station 5, say for instance, next one is station 6, station 7, you move on. For the clinical reasoning paper, if you say the diploma here, you have got 100 minutes in which you answer 10 of these,
plus some single best answer question. So it's a different way of asking something which is very, very similar. All of these questions are pretty structured. They have got a common theme in the ones that you have. In this case, a 50-year-old patient presents to your clinic for the first time complaining of general sensitivity of the left or to cold on the left side of the mouth. These are the presentation. 1, outline your general approach from initial examination of this patient to the step that you will take to establish definitive diagnosis. Now, 2 ways in which this question can be asked. If it is an OSCE situation, it will tell you list 5 factors or list 6 factors, because those marks will be very, very definitive. If you are asked to list 5 things, don't put 6, 7, 8, or 9 in, because you'll be guessing again, you do not score anything. If you put 4, the maximum you do is 4. So make sure that you think about it very, very carefully. It is highly structural. For those of you sitting the diploma here in Dublin, the diploma is a written question, so you have got a sheet of paper in which you can answer. If that's the case, put as many points as you can, because there is no deduction of marks over there, although the answers are pretty much the same. So what we're looking for is that you need to look at the complaints of the patients, history of present complaint, past medical history, past dental history, consent, extraoral examination, intraoral examinations, special tests arriving at a particular diagnosis, provisional treatment plan, stabilization, reassessment, definitive treatment plan, and undertaking of the treatment. So if this is asked for you 10 points, this is what you're expected to write. Okay? 2. What are the 2 most likely causes of clinical appearance of the cervical aspect of upper left 4? Upper left 4 tooth is here. Okay? So list 2 things. So don't put 1 in, don't put 3 in. The answer to this is either abfraction or abrasion. So you get marks on those. Okay? Now, question number 3, which goes into structure formats. Question number 3 here is list 3 differences between the 2 courses. Note, as far as these papers are concerned, question number 3 doesn't give away the answer of question number 2. Question number 2 doesn't give away the question of number 1, because these are independent events which are linked in common by the scenario. This is a common theme that you're going to have. So list the 3 differences between the 2 courses. Now, what I'm going to tell you also is that some of these principles asked in the first part of the questions are so fundamentally important. If you don't get those right, you may not score any further. But these are deliberate because these are so basic. In terms of restorative dentistry, if you don't know anything about abrasion or abfraction, you are going to have a problem practicing restorative dentistry competently. So you would not therefore be able to score the following 3 marks as well. So the differences is between abfraction or an abrasion. Abfraction, V-shaped notches, they're caused by parafunction, i.e. grinding of the teeth or clenching. They can extend below the gingival line, so these are the 3 for abfraction. And abrasion rather than V-shaped, they are saucer-shaped worn area, and they're caused by aggressive toothbrushing and or, say, for instance, not using a soft toothbrush. So you need to put that. And they are usually associated with gingival recession, because if it goes beyond the amelocemento junction, then they are much, much weaker. Incidentally, we know that, say, for instance, enamel compressive strength, then you're looking at 64 gigapascal, very strong. Cementum, no more than 4 or 5. So that is a difference, and that is the weakest link at the amelocemento junction, beyond which you have problem with gingival recession. From gingival recession, we've got problem that we identify with the periodontal problem, loss of attachments. Again, that comes with the basic periodontal examination, BPE, for which we have said that these are very good common question to set on papers, and we look at pocketing and how you basically score them as well. So what are the three most likely causes to the clinical appearance of lower left 7? Lower left 7 here that you see is this tooth here. So it's a huge restoration that is gone, and the tooth is very, very heavily involved. There is cuspal involvement, and in cases there's actually tooth surface loss and tooth wear as well. So the answer to that is that there's a mechanical failure of the amalgam restorations, plus or minus caries, secondary caries, or recurrent caries. It is as simple as that you require. If the patient, number 5 here now, if the patient is also a bruxis, i.e. parafunctioning, what other modes of treatment should you consider for lower left 7? So the patient is bruxis, which means that there is increase in horizontal alveolar loading. There is also the wearing down of opposing teeth by your own dentitions. So what do you do in a situation like this, where the excessive restoration, including the cusp? If you know from your occlusal principles, the lower teeth, the lower vertical holding cusp is the buccal cusp. The buccal cusp is gone. What do? A plastic restoration, in other words, in this situation, is not going to be successful. So for lower left 7, you're looking at a cast restoration or a crown. So you can just go over that. And for the dentition in general, well, parafunctional habits, what do? You can be asked about muscles of mastication, which Dr. Cowan has mentioned. Don't forget about the nerve supply. Don't forget about the insertion origin of those. And also, what do you do in this situation like this? You provide an upper full coverage occlusal splint like the Tanner type or the Michigan type. So that's what your answers is in relation to that. Okay? So on and so forth. This is how you score the marks on the OSCE paper, and you score the mark on the clinical reasoning paper. And I'm going to move on. Now, this is quite classical, typical. We're not going to have time to go over this, but this is a BPE probe, basic periodontal examination probe. It is very much worth noting what its functions are, where the different margins are, and where the different markings are in relation to them, where this is 3.5 millimeters, 5.5 millimeters from the tip, and the tip of which is 0.5 millimeters, which is round, and you apply a vertical pressure of approximately between 25 to 35 gram forces along the vertical axis of the tooth. You walk it along the tooth or the teeth, and you score per sextans. Look at the sextants that you have. You divide the mouth into 6 sextants. These are very common questions that can be asked. Another question that you may be asked that you need to note is the fact that wisdom teeth 8s do not actually score in the BPE score. We would ignore the pocketing of it. So for instance, if you're given a chart with upper left 4, upper left 5, upper left 6, upper left 7, upper left 8, ask you for the BPE score. If you're pocketing on the 8s and no pocketing on the 7, do not get distracted by the pocketing that you see in the 8, because this does not count. So this is to clarify these sort of concepts that you are in identifying them. Now, I will just skip this one and go over to the next one here, which is very, very similar to the lesion, some of the lesions that has been presented to you. So you have decided to refer this patient to your local oral surgery unit. The patient has had a persistent ulcer along the distal aspect of the lateral border of the tongue as presented. The patient has been a heavy smoker for the past 40 years. Now, what we're telling you is that very often in these questions, the clue and the clinical pictures go together. So you narrow down, is it a chronic lesion? Is it a traumatic lesion? Is it an infective lesion? Is it a miscellaneous lesion? Is that a growth? Is it cancer? Whatever. Just narrow it down, be systematical. You will get much further in relation to both the clinical reasoning examination when you sit a diploma, as well as the OSCE examination. Last of that, for 2 minutes, I'm going to mention about the oral examinations if you are sitting part 2 of the MFD. We've got MFD examinations coming up in the UAE. We've got those coming up here in Dublin, in New York, and in Bahrain, and a few other places as well. So we have got this common theme, is that we will pick 4 areas in the syllabus, syllabus area 2, 2.1 to 2.7, which are all the clinical areas, you are very likely to be asked questions on 4 of them. So it is a no-brainer if you are preparing for part 2, please don't ignore the syllabus, because you've got a 4 in 7 chances that you may get stuck in one of them if you don't revise that. So look at where the syllabus is, because it tells you what type of question to be asked. In vital situations there, it is a good idea, if you don't know, you can ask the examiner, please move on to another subject. But please don't say this too often, otherwise it shows your incompetence. If you say, I don't know 10 times, you've got a problem there. But if you're really stuck, rather than dig a hole in yourself there, move on to another area. Your examiner has got plenty of other questions to ask you to allow you to demonstrate competency on. And obviously, keep saying facts. You will be diverted if you keep, or you won't be diverted if you keep saying facts because you're scoring points. Your examiner will divert you to other areas he or she would like to ask you on, which is all within the syllabus. Systematic approach. Don't jump to say that, oh, this must be oral cancer. They say, yeah, correct, next slide. You'll be stuck in slide 3 or 4 or 5. But if you can tell us about oral cancer or things like this is a differential diagnosis. This is swelling. This is the lateral border of the tongue. This is elevated. Look at the history of that. These are the differential diagnoses. It is unlikely to be a chronic. This is likely to be a chronic lesion because it is unlikely just to be traumatic because it is unlikely to be infective because, etc. etc. You narrow it down. You get a diagnosis. 2 minutes is gone. You keep scoring, and then you look at treatment. By the time you finish scoring the points, move on to the next one, you would have earned yourself a very, very decent set of marks. So move on like this. The areas that for tip-wise, you look at muscle domestications, anatomy like temporal forces, temporomandibular joints, dental materials, look at these, restorative amalgam restorations, composite restoration, what they are. You look at the physical properties of them. Bleaching is a topic that comes up very often as well in relation to those. Aesthetic with biowidth, something that we covered. Restorative dentistry again. Impression techniques maybe. Hall technique that we mentioned, pedodontics, which obviously something will be covered at the end. So look at those. Space maintenance for pediatric dentistry. Law and ethics that we cover, like clinical records, clinical audits. These are easy topics wherever you sit your exams. Periodontal examination, the BPE scores, pocketing. How do you score the pocketing? When do you actually take radiographs and when do you not take radiographs? The ALARA rules. So on and so forth. Swelling, break the differential diagnosis. So in other words, what I was saying is that the syllabus is very wide. There is only a small area you can be asked in terms of survivors, but by triangulating the information amongst the 4 examiners, you will have a much wider aspect of the syllabus that you have been asked. And what we are asking you to do is to show your competency to a basic level. Nothing fanciful. It's not a specialist examination. We're not requiring those things. 1 or 2 things that, say, for instance, Dr. Friedman mentioned, very, very useful information, like the white lesions or red lesions. I would be very surprised if in the examinations you do not see any of those. Last but not least, if you do poorly in one question, do not lose your confidence. Move on to the next one. In part 2 examination, you've got 14 to 15 scoring stations. One station does not make or break you, unless if you sit the exam before the 1st of June, the CPR station, basic life support, is the station that will make or break your examination. So know your basic life support well. Okay, so we're trying to catch up with the time again. So if we have a break now, ladies and gentlemen, for about 20 to 25 minutes, so we'll start again at 12 o'clock. And we'll go through the infection prevention control lectures with you. Thank you very much. Thank you. Thank you. Thank you.
Okay, ladies and gentlemen, I hope you had a good break just now and maybe have had a cup of tea or coffee and some caffeine to make sure you're still awake, and maybe some biscuits before it ran out. No hypoglycemic attacks here. Over the next 25 minutes or so, I'm going to talk about the first topic that I was meant to talk about because we switched the two lectures over. It is in relation to infection, prevention, and control for the MFD and for the diploma examinations. This is an overview with particular relevance to the MFD and the diploma, as it related also to the practice of clinical dentistry in Ireland and many of the other 27 other European countries, soon to be 26, unfortunately. But as far as infection prevention control is concerned, the dentist owes a duty of care to his or her patients and staff. And the duty of care we have already discussed earlier on. But this is in relation to the health and safety of the patient, because non-maleficence is not to do any harm to the patient in any case. You have to provide a safe working environment for staff. You also can see that at the bottom here, this document is basically translated into so many different European languages, because this is an important document in relation to infection prevention and control. And in relation to the practice of dentistry in Ireland here, it is encompassed in the code of practice from the Dental Council in Ireland. So in other words, all our examinations as far as the standard of that is concerned in relation to infection prevention and controls are in this particular document, because this is what, if you're a registered dentist in Ireland, you need to do. And this is very, very similar in the UK with the Dental Council's guidance in the UK, as well as the HDM 0105 manuals that those of you who practice in the UK will be very, very familiar with. These are set as a standard which observe as far as possible is to allow patients to receive safe care in an appropriate environment. As John Southern says, ignorance of the law excuses no man. In other words, if you don't know about this document, it's not an excuse that you don't practice good infection prevention control. In relation to the diploma, we have seen questions directly related to this in the clinical reasoning paper, directly related to the guidance from the Dental Council, because that is what practice of dentistry is. In relation to MFD, particular part 2, the protocol for infection prevention and control is being tested. It's not so much list what you need to do out there, it's to ask you to interpret the situation, whereas then you have to apply your knowledge here to see whether it actually complies or not, and etc., like segregation of waste and others. It is important for all dental professionals in Ireland to observe this because of the Section 66 of the Dentists Act 1985. I know that in this jurisdiction here there is the talk that a new dental act will be coming in at some stage, but this is what the legislation is now. The Dental Council is committed to high standards of patient safety and welfare. Intended this code will be used both by dental profession and the members of the public. Now, given the history of the diploma examination itself, which was in 2012 completely approved by the Education Directorate of the Dental Council, we are examining in this level exactly what the Dental Council requires you to do, whether it's diploma, whether it's the MFD, or whether it's the FFD examination, is the same standard of infection prevention and control. One characteristic of it is that there's plenty of paperwork, plenty, mountains of paperwork. Have you got your paperwork in your workplace ready? Because it says all dental practices must have written protocol, blah, blah, blah. Note the word must, there's no exception. These protocols should include, so you have to have a very good reason for these paperwork not to include these policies. With policies, with protocols, that means that you really have very, very little room for maneuver as far as the practice of dentistry is concerned, because it also said at the back that all dental practices must have a protocol for dealing with exposure, etc., etc. Note the word must again. It's a compulsion. In other words, in relation to sections 131 and 132 of the syllabus, in the OSCE situation, these must situations, it is very easy to set the questions on. And I'm going to come into some of those potential questions with you later on to give you some tips on. The concept in infection prevention and control is that there is a universal standard precaution. The hand hygiene, respiratory hygiene and cough etiquette, environmental cleaning, etc., etc., etc. at the back, which we're going to go into one by one. For the first time, the exposure-prone procedure, EPPs, have got different categories because you're categorizing them in terms of the risk that you're going to have. In other words, that if in operation of the operative dentistry, the fingertips that you have is an operator is outside the body, there is a much less risk of infection, cross-infection with the patient. Number two, if the fingertip is sometime out of your sight, i.e. in the patient's mouth, higher risk. Number three, the fingertip is out of sight for a significant time of the procedure or during critical phases, there is a much higher chances of cross-infection control problems. In other words, you have to have implications of risks, what risks are, and therefore methods of preventing them, and management of these problems and remedies. So these are the risk category with which you need to be very, very careful of. For the first time, the universal precautions of infection prevention and control is reclassified with these. Hand hygiene. If your hands are not visibly soiled in between patients, you can use an alcohol-based hand rub in relation to the hand cleaning using the A-lift technique. Number one, A-lift technique can be a question that can be asked. And number two, contents of the alcohol hand rub and what they are. Good multiple choice questions. When the hands are visibly dirty, contaminated or soiled, wash with non-antimicrobials or antimicrobial soap or water. Infection prevention control, bare below arm for infection prevention control process as well. And the nails, don't keep nails and use some moisturizers can compromise that as well. This slide there, you do not need to memorize those as such, except that you need to know where the personal protective equipments are. Protective eyewear, protective mask, protective gloves, tunics and uniform, these two main form. What you need to know is as far as the mask is concerned, down here, there are two different types of mask. The standard mask is up to 97% filtration. It filtrates particles up to 3 micron, but it is not effective against SARS, TBs, or influenzas. So in an OSCE situation, if you are being asked to identify two types of masks there, identify them, because the N95 masks, if you have a picture to look at them as such, that they are very, very classically say N95, and they have got a better filtration and therefore more effective. But in any case, once they are moist, they are ineffective as a barrier. Gloves as well, you need to use either natural latex gloves, in which case you have got potential of type 1 allergic reaction, as opposed to type 4. You need to know a little bit about them. And if you don't, then the nitrile gloves, what they are, and the vinyl glove, the advantages and disadvantages. Use of tunic as well, 60-degree washed, set it in this particular position. So note that in this situation where if you are you're being tested on the gloves, you're being tested in physiology as well, which we haven't mentioned, about mast cells, lymphocytes, and others, in relation to type 1 and type 4 cell-mediated D4 and T cells reaction. So you do read about them. Importance of zoning as well. In operative dentistry, you need clearly defined clean and contaminated zones. You need to have material to flow from the green zone, which is a clean zone, into the dirty zone, which is a clinical area, in which when you effect decontamination there, you must be able to decontaminate it. In particular, the red zone, because this reds mean danger. You also need to have impervious surface barriers to protect areas of equipment that are difficult to decontaminate. And you, once again, classify risk like this. You need to be able to manage the biofilm very, very well, waterline biofilm. The biofilm is made up of bacteria or aggregate of bacteria or formites, which they are very, very different from the normal behavior, and we're going to go into that in a minute. Safe to say that in dental unit waterline, you need an independent water supply using distilled or reverse osmosis water. You need a type A air gap. In other words, you're not going to cross-contaminate the water supply by any contaminants that you have otherwise. You also need to have anti-retraction valves in handpieces, particularly high-speed handpieces, so that there will be minimum amount of backflow of infected material. You also need to dry them out each session, in between sessions, or at the end of the day, and wash them and clean them, flush them with disinfectant, so that without water, without moisture, we show you what it does to the biofilm itself. So you have to also assess the risks in relation to what your practice are. So the thing that you could be asked in relation to this is that there are problems with, say, a handpiece. What features of this particular handpiece would be required to minimize infection prevention control problem? You need anti-retraction valve, you need X, Y, and Z, like what we have suggested before. Surface decontamination is very important as well, because you need to minimize the recontamination of the materials and, say, the work surface. So there is pre-sterilization decontaminations, and there's also the processing of the materials which need to be sterilized. In other words, what we're trying to do, and look at this particular graph in the middle, is that we need to use the method to reduce the bacterial load before you actually sterilize them from this bacterial count all the way down. And from there to zero is much, much easier to reduce. So in theory, you need to have hand washing sink plus two other sink, or plus one sink plus two bowls, in order to minimize the contamination when you handle the material. You also need a biological process, use of alkazymes, in order to reduce the loading in bacteria. You also need a protocol for mechanically scrubbing and cleaning, or ultrasonic use of these materials to reduce the level of contaminants. You need to have measures to avoid splashes or splutters, and you also need to clean your handpieces effectively before they're being sterilized. Obviously, in the surgery, you need a zoning system, because the dirty zone needs to be cleaned out effectively, particularly in between the patient. You also need to use barrier method, particularly in the areas where we have mentioned that it's very difficult to clean. In practice, you need to be able to transport contaminated instruments from one area to another. But you, in theory, need to keep it to a minimum, because the more you transport it, the more risk you take. But you do have to, from time to time, so you carry these materials in a secure container if it is transported. And you need to make sure there is no contact between the contaminated and the clean sterilized instruments, otherwise then all the infection prevention and control measures and efficacy goes very, very quickly. And these will be useful for all sections of the examinations, and for a few members of the audiences who will be sitting the license exam, bench test. These are one of the area of competencies that is legitimately being looked at as well, both in Ireland and the UK, for those of you who may be doing that examinations. So in terms of transportations, you need boxes, or you need cassette container with the rigid, leak-proof, easily cleansable, and capable of being closed securely, so that when you transport from one room to another, it's not going to fall on the floor completely. You also would need to consider the use of water disinfector. Now, water disinfector is not the most effective means of pre-sterilization cleaning, but it is a very effective means of doing so. Reason why they are being recommended is because they are reproducible, they are verifiable. Somebody will scrub very well, somebody will scrub very poorly, you don't know. And scrubbing, it can lead to abrasion of the skin, injuries, and other problems as well, whereas water disinfector does not. The problem, though, is that it is highly technique sensitive. It must be commissioned, validated, and tested. So validation is verification and tested with documentations so that it actually reaches 80 degrees for 60 seconds. But the problem you will find in clinical practice is that it will greatly increase the amount of materials and instruments that you need, because this process takes a very long time, 40 minutes, 45 minutes. Ultrasonics may be used, but these days it is as a measure, as a cocktail of measure to decontaminate them rather than just a standalone measure before you sterilize them. So manual cleaning, they're high risk and low efficiency and reproducibility, so in theory it should be avoided. So you've got preparation and packaging as well, so you need to be able to examine the materials very carefully under lighting conditions. You need to be able to inspect them after cleaning under magnification. They must be free from visible contamination and dry after the washer disinfector, because we know with moisture the chances of contamination is much higher. You can actually pack them before you sterilize them if it is a vacuum autoclave, which we'll go into in a minute. So autoclave, there are three types. Now I will highlight them in red because I've seen many a times in both in part one of the exams, in diploma exams, and in MFD2 that these questions are being asked. So there's three types of autoclave, or mainly two types, vacuum and non-vacuum. But three types in the sense that you've got type N, which is a non-vacuum autoclave. It works by downward displacement of air, limitations on the use to sterilize lumen instruments. Type B, which is vacuum, in strict conformance to European Union standard, or type S, which is vacuum, but they prove equivalent as per the manufacturer. The difference between type Bs and type S is that type S does not actually have to be vacuum, drawn 3 times, triple lock, etc., etc. As long as they can demonstrate same efficacy, they can call themselves type S sterilizer, vacuum sterilizer, because it conforms with the outcome, but not the exact process, so that if it is a vacuum autoclave in accordance with the European Union process that you draw vacuum 3 times, etc., it will be a type B. You, in theory, should have a central sterile supply department, and you have protocols of storage, and you need to verify them, the paperwork, and you need audit now. So don't forget audit, clinical audit cycle that we went through. So key points about vacuum autoclaves are they are more expensive than non-vacuum counterparts. They need straight verifications, but because they are vacuum, there is better penetration of steam through the vacuum, and therefore more effective sterilization. So therefore it can sterilize instruments with a lumen. It can place instruments in pouches or bag before you sterilize them. And therefore, because it is dry at the end, there's less corrosion of the instruments, so instruments actually last longer. Instruments are dry at the end of the cycle and conform to the current gold standard of autoclave. The only thing that sterilization procedure does not actually get rid of or remove will be the prion molecules of new variant CJDs and the such of it. And so there is one exception of that. But because of the very, very low prevalence of this particular problem with the Krasnov-Yakov disease, this protocol is not being carried over into these guidance as a result. What do you mean by vacuum? It has been asked. Vacuum is the void of space, space void of matter. An approximation to such vacuum is the region with the gaseous pressure, which is much less than atmospheric pressure, not zero. So in other words, when you say that it's a vacuum autoclave, it doesn't mean that all airs are completely out. Most of the air is out, so that the atmospheric pressure of 760 millimeters mercury is way, way down. In replacement, the steam penetrates through the cassette or through the vessels, and that forms the steam pressure. So although you are sterilizing by vacuum, it is not a complete vacuum because you've got water vapor pressure. So if you are asked what pressure, 134 degrees, which is a gold standard for a vacuum, for autoclave, 3.5 minutes, what pressure is sterilized at? It sterilizes at 2.2 bar pressure, which is the same as 220 kilopascal, which is 32 psi, pounds per square inch in all imperial terms. And this is because of this, and this is because of the fact that you have got pressure from steam, not from air, from steam with moisture and water at the temperature which penetrates through the lumen. There are periodic testing that is required, Bowie-Dick tests, Brown's TST strip. I haven't seen Bowie-Dick tests being tested in your exams, but Brown's TST strips and biological test strips are questions that can easily be asked. So you need a steam penetration test. In other words, that if it's a vacuum there, you would place the a paper, a Brown's TST paper in here, and you would allow the vacuum to be drawn so that if the vapor enters this end, goes in right through all the curve and sterilize and reach the same satisfactory temperature here, they will all turn color on the inside because steam has penetrated. That's the steam penetration test. And also the spore test as well, biological tests, which are the definitive provisions of whether the sterilization process has been completed, whether any spore would actually survive in them. You also perform the air leakage test, but the air leakage test is only performed in a warm environment because once it's above a certain temperature, then this becomes ineffective because you've got more than 1 millimeter mercury per minute increase in temperature, and that is one of the reasons why a lot of new autoclaves, vacuum autoclaves, seem to fail the air leakage test. It's not because they fail, it's because the parameter of the temperature set is not correct, and so artificially, with a higher temperature, there's a much higher increase in mercury pressure on its own. You need local decontamination room as well, which I'm going to move right on, because the local decontamination room allows the instrument flows from the clean zone from the dirty zone to the clean zone. And the instruments are coming in here, you wash, ultrasonic, you rinse, and you sterilize, inspect and storage, it goes out here to the clean zone. And air is traveling from the clean zone to the dirty zone in ventilation so that you do not contaminate that. And there is a two-way door in theory as well so that you do not contaminate yourself here, and then wash things and other wash basins as well. So this is the setup of the decontamination unit. Looking at clinical waste, you have got special waste, you've got clinical waste. But what I'm saying in terms of the exams is that you need to know these signs, what they are, because they are very easy questions to ask. And you also need to know how to dispose of hazardous waste in terms of sharps, amalgam, fixer, or developers, because you cannot throw them down the sink. Disposable waste, you need to know what the sign is. You do not use these items twice, i.e. they are single-use items, like for instance masks or gloves. You need to know the European Union directive on how to manage mercury in terms of amalgam, including extracted teeth. With amalgam, you will need to store them in strip lids, in seals, vapor suppressants, and they need to have the mercury recovered in the processing as well. As also the Osprey Convention and the Minamata Convention on use of mercury and use of use of amalgam, and the amalgam separator test as well situations. How do you decontaminate impressions? Well, it has to be a protocol which you wash and rinse, and when you use compatible disinfectant like sodium hypochlorite. Now, sodium hypochlorite is an agent that you use for multiple purposes. And again, picking it up, these are very clear questions that can be asked in terms of multiple choice, say for instance. But you need to have paperwork again. I'm not going to go through this in great detail, except that you need to read up about how you manage Sharp's injury. MFD Part 2, Oskis and virus. A lot of questions can be asked from here, which spins out to clinical audit, which spins out to how you manage different things as well. Patient and staff protection, you know where they are. The only thing I say is that the HPV 16, which is not applicable for in these circumstances, the link it has potentially with oral cancer, and you cannot ignore these particular situations. But beware of other emerging infections. So in the big stop whistle tour itself, ladies and gentlemen, I'm 13 seconds over, but thank you very much for listening, and I hope you enjoyed it. Thank you very much. Thank you. Thank you. Okay, thanks, John. Our next speaker is Dr. John Walsh. Dr. Walsh is the immediate past dean of the faculty, and Dr. Walsh is going to talk about pediatric dentistry. Now, as we mentioned in the tips for the examinations, this is